Dr. Boyle, thank you so much for a fascinating presentation. I'm sure that you may be wondering, as I am, does what we have just seen, a really fascinating macro view of prostate cancer and cancer throughout the world, does it have something to do with diet or climate? I mean, why does Norway have such a high mortality rate? Why does Korea? Oh, sorry, Jeanette. Try it again. Why does Korea have such a low mortality rate? And if I could tell, by the way, just referring to one of your last statistics, Dr. Boyle, 10 years ago, I was having an annual checkup with my family physician, and I had to ask him for a PSA test. And he said to me, "Are you sure you want it? It's not covered by your insurance." And I said, "My father had prostate cancer, yes." He says, it's going to be $65. He was discouraging me from having a PSA test. Well, he's no longer my physician, needless to say. And I hope and fervently believe that that attitude is not prevalent in the medical community. I certainly don't believe it is. I see George Foyo from Baptist. I'm sure at Baptist, George, they don't say things like that. Could I ask our panelists to come up to the stage, and we are going to move on to our panel. And once again, there are these little note cards on your seats, and if you have a question, perhaps about what Dr. Boyle said, what the panelists are going to say, we will certainly try to get to them. Also, Dr. Boyle, I would say that maybe Rudy Giuliani needs to consult with you. A couple of weeks ago, Rudy Giuliani said, I'm a prostate cancer survivor. In this country, there's an 82% success rate in treating prostate cancer. I'm sure glad I wasn't in the United Kingdom, because they have a 44% success rate in treating prostate cancer. The point he was trying to make was, in a country with socialized medicine, they don't do as well as they do in the United States. And as Paul Krugman wrote in a column in the New York Times last week, Mr. Giuliani, Mayor Giuliani, had his statistics entirely off, and the statistics that Dr. Boyle has just presented show what the truth of that matter is. Well, let's move on to our panel, and they are now assembled. Good morning to all of you. Really people who bring a different perspective, a different history, different knowledge to this subject, each of them their own story to tell. And I'm going to start as they are listed here in the program. What I'd like to do, panelists, is to ask you to speak for just a couple of minutes from your perspective, your point of view. And then we are going to open it up to some questions that I may have, questions for each other, and questions from the audience. So let's begin with perhaps the most famous member of the panel, and we're so glad that he is here from, is it Ohio where you live, Ken? I'm not sure where.
No, I live in Florida.
Oh, you do live in Florida?
Yeah,
well, great. Well, anyway, one of the great baseball players of our time, maybe of all time, Ken Griffey Sr., who is a prostate cancer survivor. Ken, welcome.
Thank you. My experience started probably about a year and a half ago. But actually, it really started before that. I'll give you a brief history that my doctor and I went through. All my uncles, every one of my uncles, there's 6 of them, had died with prostate cancer. So during that time, they were older, you know, in terms of anywhere between the mid-70s to 80s. So a lot of them never really got checked. So and my experience was get the PSA, get checked, because of the fact that, you know, the high risk, like I say, in black males, is a high risk factor in prostate cancer. So that's mainly the reason why, you know, I mean, being in baseball for over 30 years, we really never got checked the PSAs or prostate cancer test during the season or during the regular season in terms of spring training. We had a regular physical, but they never checked for that. So right now, my son Junior and my son Craig, they get checked frequently every year because of the situation I've been going through in the last year. I've recently had the surgery 4 months ago. It's been an experience for me. I didn't know all the things that it would take. I've changed my habits a lot. The funniest thing is that I go to Walmart at 3 or 4 o'clock in the morning, because of certain things you have to get. And the incontinence, as most of you know about. Those things have changed a lot of what I do in my career, in my life now. So, but it's important that, you get checked and make sure, that you want to be. I have 14 grandkids, so I want to be around for all of them. And that's the big thing for me, is I just want to be there and help them as much as possible. That's briefly my little story, and, if you have any questions, I guess we'll all be here to answer questions.
Ken, thank you so much. Now we want to hear from Pam Downey, who is a physical therapist. Pam, good morning to you.
Good morning.
Hold that mic up a little bit closer, please. Thanks.
I work on more of the quality of life issues for patients. I've been dealing with incontinence in prostate survivors for about 10 years now, and we really look to increase the functional capacity and the quality of life. There are many different avenues of treatment, but physical therapy isn't one thing that was typically used by the urology community. It's very common in neurology and orthopedics. Everyone gets their knee fixed and gets some rehab, but generally patients were referred for physical therapy after their prostate surgery. And Dr. Krongrad was very important in my early training because he had an ear for this, to see that physical therapy was rehabilitation and could improve quality of life for these patients. And a recent paper in 2006 in the Journal of Urology showed that physical therapy done right after procedure brought patients to continence in 3.5 months versus the control group that didn't seek continence at over 12 months in 50% of the subjects. So it's really a trend that is improving. People are seeking treatment, and I'm finding that education of the consumer is much more important. Just like Mr. Putney had suggested that you don't have to ask for your prostate or PSA screening, you shouldn't have to ask for physical therapy. This should be part of a normal protocol. So part of my aim in my training in pelvic floor dysfunction and incontinence is to promote education so that people can seek treatment earlier and have better quality of life outcomes.
I wish I had the option of physical therapy. I mean, I was told some exercises, but it sounds like something that certainly I don't know if Ken has had that option either, but it sounds like a great idea. Now I want to introduce a neighbor of mine, a friend who is the daughter of a prostate cancer patient, a survivor, Jeanette Kaplan, who also works in the media.
Hello, I'm here not as a journalist. I'm here as a daughter and also as a mother. I have a son, so I'm worried about what might happen to him in the future. I know a lot about different topics. When my father was diagnosed with prostate cancer a year ago, I realized I knew nothing about prostate cancer. And speaking to other people, I've realized that this is a common thread. That is why we are here today, because we want to break the silence. I think that as a family, it's more than 1 in 6 families that are being touched, because a lot of families are being touched more than once by this disease, as King Griffey was telling us. And I really think that the family, the women of prostate cancer have a really active role, a very important role. When somebody is diagnosed with cancer, the first thing that they think is that, am I going to die? And then they can have different reactions. They have fear, they might have anger. And as a family, you need to stick together, or it might be a friend. And you need to play a very important role. The person needs to make their own decisions, but it's such a confusing and overwhelming time that if a loved one of yours is going through this, do not leave them alone, even if they try to push you away. You have a very important role in supporting them, and it's such a crucial point in a patient's life that you need to help them make the decision. So many people, when they are confronted with the diagnosis of cancer, and prostate cancer specifically, they just say, you know what, I'll just wait and see what happens. The problem is that you do not know what might happen in a few more months, and that is when the support system really is crucial to make decisions. Not everybody needs surgery, not everybody will need radiation, but probably you will need to do something about it, even if it just means testing every few months. So I'm here to answer any questions, not as a professional, I'm not a doctor, but I am a very concerned person who has learned to be much more aware of this disease, and I'm trying to help other people learn about it as well to avoid more men suffering unnecessarily.
Jeanette, great, thank you. Next, I want to introduce Dr. Donato Arguelles, who is a internist. Dr. Arguelles, please.
Good morning. I'm a local internist cardiologist in this community based out of Coral Gables, affiliated with the University of Miami. And I was invited, I guess, to deal with any of the questions that we've already seen on the plate today. It's a shame in today's day and age that Ken and Mike have to ask and almost beg to look at the PSAs and examine the prostates. And if you look at some of the issues involved, you'll see that not only is it the dreaded rectal exam that everybody's afraid to walk into the physician's office for, certainly there's physician factors that don't favor either talking about it or dealing with it. And I think that as you come to your doctor's office, there's an initial factor that you should keep in mind, and that's the historical factor that we've already seen. We know that if you have a brother or father who's had prostate cancer, your risk of having it is doubled. If you have 2 siblings, it's 5 times, and if you have 3 siblings, it's 11 times. Unless you know that or your doctor asks you that, they're less likely to investigate and investigate more thoroughly the possibility you may have it. The other thing that I ask for in my patients always is symptoms of prostate, whether they're having any symptoms that they're having difficulty with an enlarged prostate or any symptoms that might be referable to this. So these are things that need to be talked with your physician. I will tell you that I've routinely started screening PSAs into the 4th decade. It's been taught for many years now in medical schools that once you reach 10 years from your expected life age, and I guess for men today it's in the 75-year range, that you shouldn't screen for prostate anymore, because by the time you find out prostate and the time you die from the prostate, you would have, passed your life expectancy already. Well, we know that that's a lot of BS nowadays, because who knows? I mean, how many patients go to 85 and 90 and 95? So we have, as we've seen, have an aging population. You do need to stick with it. And, you look for a rational screening method, and this can vary across the table, and we certainly have experts on this panel and today that can deal with this in much more detail than I can. But there was a study published in Prostate in the year 2000 that looked at almost 15,000 patients in Canada that came for initial visits and almost 45,000 follow-up visits, and found a very simple regimen which very clearly can impact the discovery of prostate cancer. Because the critical feature, in my opinion, is not just discovering prostate cancer. You want to discover prostate cancer when it's localized, when it's still within the prostate. Okay, that's the critical feature. And to do that, what they suggested after analyzing many patients over several years was that if you did a screening PSA and you used a cutoff value of 3, and you'll see that most of these PSAs have a cutoff value of normal for 4, and use that as the initial screening test, and then anybody over that went to the second level, which was the digital rectal examination, the prostate ultrasound, and/or biopsy if needed. It becomes, number one, a much more accepted way of screening prostate. And in their group, 99% of the men that were discovered to have prostate cancer had localized prostate cancer. In other words, potentially curable prostate cancer. So don't be afraid to talk to your physicians about this. You need to bring it up. You may need to push them to do the appropriate testing, but I think that you'll see that there's 2 men on this panel here that serve testimony to the importance of doing that. Thank you.
Dr. Arguelles, thank you. And we're also fortunate to have an oncologist with us this morning, Dr. Michael Schwartz. Dr. Schwartz, good morning.
Thank you. Hi, my name is Mike Schwartz, and I am a medical oncologist. I am co-chief of hematology oncology at Mount Sinai Medical Center right here on the beach. My initial training was at Mount Sinai in New York, and then I went on to do a fellowship at Sloan Kettering in New York. And while there, I had the chance to do some prostate cancer research, and when I came to Miami 15 years ago, I was able to extend some of that research, being one of the investigators in the prostate cancer prevention trial, which was a nationwide trial. Over 15 men participated, looking at pharmacologic medications that might reduce the incidence of prostate cancer in men who are at high risk. We continue to participate actively in clinical trials, both for active treatment of advanced disease and prostate cancer prevention. And I thought I might want to, as a medical oncologist, like many of us, I've also been touched in a personal way by prostate cancer. My father was diagnosed with prostate cancer 4 years ago and was treated with radiation and is doing well. But I think, as you mentioned, this is something that there's nobody out, you can't walk into anybody in the street whose life hasn't been touched in some way by prostate cancer, and I think people are beginning to realize that. If I could just address a statement, of course, you made, and that was brought up by a member of the audience based on one of the slides. You know, the striking difference in incidence between some southeastern countries, China, Japan, compared to the United States in prostate cancer. Now, it's true, we're not sure why that is. And there's certainly some genetic reasons, but there are some clues that it has to do with our lifestyle. For example, if you take someone from Japan, second generation, their incidence of prostate cancer approaches those of an average American. And it appears to be the leading theory right now, it has to do with saturated fat. I mean, the same culprit for heart disease and a lot of key health issues seems to also be playing a role in increasing the incidence of prostate cancer. There's other theories, maybe livestock being exposed to hormones, that's not as well established. But I think we do have a partial explanation as to why the incidence is so high here and not so, and much lower in other parts of the country. And it gives us some clues as how we might improve on that.
Excellent. All right. Thank you all very much.
Use it as a method to pick out people who are at risk. Now, the PSA is being refined. There are certain techniques, such as the free PSA level, complex PSA level, which are more specific in actually picking out a person with an elevated PSA who truly does have cancer. But, you know, the PSA is not the end with all of prostate cancer. It just picks out the people who need to be followed more closely.
Right. And Dr. Arguelles, that leads to another question, which is the PSA test the only test to determine the evidence of prostate cancer?
No, as I briefly alluded to, there's the digital rectal exam that everybody hates, and the ultrasound. And the PSA can be confusing because I mean, I have a patient in this room that had a PSA of 1 at the time that he was diagnosed as having prostate cancer because he had a brother with prostate cancer. So it can be confusing. There is some data that PSA levels will fluctuate normally, sometimes up and down over the course of perhaps even a year if you sample multiple times. And there's also recent studies showing that more important than the absolute PSA value is what is increasing in PSA. In other words, if you exceed a certain increased percentage in PSA, and what they were using in this was 0.8. If it increases by 0.8 on a yearly basis, that's not a good sign. But the PSA serves for us as an initiation in the evaluation. And certainly if there's any other doubts and symptoms, for sure, there should be a digital rectal exam. The digital rectal exam, unfortunately, has a low specificity and sensitivity, as the way we like to talk to in medicine. It's not very sensitive and it's not very specific, but it is helpful, and it can find some patients that are not picked up by the PSAs. And when you diagnose prostate cancer, 90% of the diagnoses eventually come from the PSAs, but there's 10% that don't. And that 10% are the ones that are picked up with a digital rectal exam and with a prostate ultrasound. And so those are complementary tests.
Pam Downey, here's a question from somebody in the audience who says, where can I get more information on physical therapy in regards to erections? Is there any way that physical therapy can help a man who is impotent as a result of the surgery?
Well, a typical physical therapist, just to educate you, it's not entry level. It's not something that's taught to every physical therapist. I went back and I worked on specialties like a fellowship, basically, in doing pelvic floor and incontinence work and did continuing education. So one of the things when you're looking for more information or trying to follow up with a physical therapist is to find someone who has the specialized training. I'm associated with the University of Miami. I'm faculty there, and we have a training program for our physical therapists, and I do continuing education. When it comes to incontinence and erectile dysfunction post-prostatectomy or with any sort of prostate issues, including urgency, frequency, and the erectile dysfunction, you have to really look at the source of it. Up to 60% of erectile dysfunction is organic, so it is related to what may have been injured during the surgery, because of course the cancer is what you want to remove, and so you have better outcomes on your mortality, correct? So if the person had a procedure where the nerve was injured, there's going to be different outcomes for incontinence and erectile dysfunction. So there's vascular components and also psychogenic, meaning how you think about yourself if you're depressed about your situation. So getting to the physical therapy component, we evaluate those different areas, and we can look at the different aspects of what function you do have. There's medication that we use in conjunction with physical therapy, and it's to pursue that you can contact the American Physical Therapy Association. And specifically, the section on women's health, it's a misnomer, but we treat men. Half of my practice is men. And you can find a person in your community that can treat this through the website on the apta.org. So some typical treatments that we work on is to make sure that your pelvic is working. What's a pelvic floor? Is that a room in your house? Well, this is something that we educate on to see if you actually have a good mind-body connection. We look at vascularity and blood flow. We look at how your activity is. There's many, many different facets. So there is some promising treatment for that, but it really does vary by individual and what the physiological picture is coming in, neurologically as well as physiologically.
Excellent answer. Thank you. And Ken Griffey, Sr., let me ask you a question, and I'm asking as somebody who has had prostate cancer to another one. Two of the big issues that everybody's been talking about here are impotence and incontinence, and you refer to going to Walmart at 3 a.m. I understand that. You thrived in a very testosterone-laden world, professional athletes. It's bad enough for a regular guy like myself to, I think, or anybody any man who's had prostate cancer to, say to your friends, I've got prostate cancer, and you see the look go across their face, well, is he going to be impotent? Is he going to be incontinent? If you don't mind, tell us, how did you deal with that question when you were dealing with people within the world of professional athletics?
Well, I kind of dealt with it head on. I mean, it's one of the situations that Dr. Krongrad and I talked about frequently, that it may happen, and just depends on the timing, how much time you have. So I'm looking at, I just had the surgery 4 months ago, so I still have some time, and we've been talking about it day in and day out, but it is a situation that kind of gets on my nerves, trying to deal with this. And, I have my wife, and like you said, you need a support staff that's going to be there every day for you. So those are the people that I count on a lot to talk about certain things that are going on in my life in terms of the incontinence. You go through so many changes with it. I do a lot of traveling, and certain things I have to take with me, and then when I go through the airport, somebody looks at me real strange with it, so I just have to deal with it the best way I can. So I'm doing it day in, day out. I try to stay calm about a lot of stuff, and I want things to happen quickly. Being an athlete, those are the things that you always had. Everything happens so quick, and you know how to make adjustments time in and day out. So this is a situation that it's going to take time, patience, and like I said, when she talked about support staff, family is probably the most important.
Great. A good answer, and I applaud you. That's the way I tried to deal with it, was straight on, but sometimes at 4 o'clock in the morning, you're just lying there awake thinking about these things. You're worrying. Jeanette, here is a question for you. It's as part of our mission of the American Prostate Cancer mission, is that we are establishing a patient navigation program giving prostate cancer patients and their families through the illness. Do you think that this kind of navigation system is worthwhile, and what do you think is the best way to get women involved in it?
Well, I guess there are two parts to this question, so I'll give two different answers. Right now, there is so much confusion regarding treatment, regarding diagnosis, regarding testing, that I think that any kind of navigation that you're able to offer is helpful. It might not be equally useful for everybody, but I do think that at least one person will benefit from this. And not only the patient benefits, the family benefits as well. And that leads me to the other part of the question, which is, how do women get involved? Well, obviously, I don't have a prostate, but I have a father, I have a brother, I have a son, I have a husband. And that is how you get women involved. You realize there are so many men in your life that maybe will get touched by this disease, and that affects you directly, because it will affect how you relate to this person. It will affect your state of mind. It will affect and change your life as well, because even though we might continue to make bad choices when it comes to eating, and maybe we're not as active as we should, you start realizing that, look, you know what, you're 45 years old, why don't you get a test? That's what I do with my male friends, or with my friends' husbands. I start trying to influence them, and it's just a matter of starting to talk about it as well. Since this deals with these two major issues, which is impotence and incontinence, a lot of men don't want to be talking about this because this affects their women as well. Women need to understand that they have a role in making men comfortable talking about this as well. It does not mean that you're less of a man if you need to wear diapers at a certain point because you're incontinent. It does not mean you're a less man if you are suffering from impotence. it means a lot more for you to be here today and to able to enjoy your life, to enjoy your children, to enjoy your grandchildren. This is a matter sometimes of life or death. And in the sense that we start talking about it, I think that it helps people realize that they're not alone. When people realize that they're not alone, it reduces their stress level. They start to talk about it, and you start helping others as well. So that's why I'm urging any person that I know, be it a man or woman, get involved, be aware, and just lend a helping hand to somebody who might be in a lot of need right now.
Dr. Schwartz, here's a question. Somebody wants to know proton radiation. What is it and how effective is it?
Radiation can be delivered in a variety of means. There's external beam radiation, which is what most of us think of when radiation is delivered with standard X-rays. There's brachytherapy or seeds. And proton beam radiation is a form of external beam radiation using proton as the isotope. It's used in very few centers in the country right now. I don't know if there's more than a handful. It may be able to deliver a higher dose at a smaller target with some scatter. I would consider it still promising but investigational, not really established as better than the techniques that we have available now.
Mm-hmm. All right, Dr. Arguelles, here's a question. This gentleman says, my urologist prescribed Viagra for my erection. This does not work for me. What are other alternatives that I may have? Are there other alternatives?
Yeah, first of all, as you talk about the ED medications, it's important to get your internist involved because you should discuss with him what the risks are and how they're applicable to you. Is there any screening that should be done? And some of the ED medications, it's not just Viagra. There's several types of similar products that have some advantages and disadvantages. In addition to that, there are other pharmacological treatments, including urethral suppositories, that can work. Unfortunately, when there is significant nerve damage, and I'm sure some of the urological consultants that will be speaking throughout this morning may deal with this head on. When there is significant nerve damage, you may be relegated to other things such as implants, etc., and some of the other impotency techniques that they have developed. But it is treatable, and frequently treatments are successful. But they should be discussed up front, and most of the time, certainly in the crew of competent physicians that we have in this room, they're dealt with head on from the very beginning as a major portion of the discussion. And a lot of your decision making as to who should or should not be doing your surgery and where not it should be done sometimes can reflect that. That's a very important thing to consider when you go to considering your options for the treatments.
And Dr. Arguelles and Dr. Schwartz, here's a question. Would extended use of a catheter prior to surgery delay recovery from incontinence? Either one of you?
I mean, I think actually it's a question for a urologist. I would say yes, that's one of the issues which determine the likelihood of incontinence, whether somebody has had either a TURP procedure or prostate biopsy before, but I'm not fully able to comment on that question.
Sure. All right. There are a number of other questions. We've sort of covered a lot of ground, though, and I think some of these questions we've answered as many as we can right now. So if we would please thank our panelists for their contributions.